It is time for what you live and breathe for. Another Persiflager's Puscast. This one covering the last 2 weeks of August 2011. Now, I have to say my usual stuff. This is brought to you by Pusware LLC, publisher of the Infectious Disease Compendium, a Persiflager's Guide, your uber hyperlinked electronic guide to infectious diseases at pusware.com. This is no longer CME accredited because the requirements were too much of a pain in the neck. So not only do I not have to go through the usual rigmarole of the CME, I no longer have to mention my conflicts of interest, which are still zero, but still I am for sale. References are available online. And of course, my growing multimedia empire can be found at moremark.squarespace.com, where you'll find links to my blogs, my books, my iPhone apps, and my other podcasts. Because the world needs more, Mark Crislip. Finally, I know the rest of the country has been suffering an ungodly summer with awesome heat and humidity, where the Pacific Northwest, the great Pacific Northwest, has had nothing but clouds and rain and will be long remembered as the year of the green tomato. Well, this week the weather is nice, and I'm sitting out on the front porch to do this. Because I'm sitting in the front porch, you will hear extraneous sounds, the fountain, the occasional car going by, and perhaps even one of the endlessly barking goddamn dogs in the neighborhood. Live with it. I would much rather sit outside on my front porch and enjoy one of the few days of summer than have the extraneous sounds be gone. Now we shall move on to the Puscast. There was an interesting report in Conflict and Health entitled Detection of Infectious Disease Outbreaks in 22 Fragile States. What they did is they went back and looked to see where the outbreaks occurred in fragile states and what the organisms were. And they found a lot of outbreaks in fragile states. What, you ask, is the definition of a fragile state? Well, according to the WHO, a fragile state is, quote, a country facing severe development challenges such as weak institutional capacity, poor governance, political instability, and frequently ongoing violence or legacy effects of past severe conflict, end quote. Sounds like the United States currently. I know we're not that bad, but still. Poor governance and weak institutional capacity, that kind of sums up our country right now. But what was remarkable is that they found 38 separate outbreaks in these fragile countries, and there was often a month or more before they were reported. The even more depressing thing is that one of the reasons they found these outbreaks was due to hunting down rumors. So these are important crucibles for future infectious diseases, and it is important for the world to know what's going on in other countries. Not that we'll ever do anything about it, but still. I found it interesting the number of outbreaks that occurred in a 10-year period, as reported in this paper. I know, we need to sell more gabapentin. That would be a great idea. How might we do that? Well, let's do an uncontrolled open-label study, and let's give everybody coming through our clinic valacyclovir plus gabapentin and see what their incidence of postherpetic neuralgia is. Well, they did that in 133 patients. And they found that at 6 months, the incidence of postherpetic neuralgia was 9.8%. Usually, it's around 12%, so not that different. This was not placebo-controlled. This was not blinded. And then they conclude, and here's a quote, "The combination of gabapentin and valacyclovir administered acutely in patients with herpes zoster reduces the incidence of postherpetic neuralgia." End quote. What a load of shit. Seriously. You cannot make that conclusion whatsoever without a randomized placebo-controlled trial, especially since your endpoint suggests that you have the same amount of pain as patients who get nothing. This was done to sell gabapentin. The archives of dermatology should be embarrassed. And not unsurprisingly, if you Google the title of the paper, you get completely gullible reproductions with no thought whatsoever behind the study. This paper is archetypal garbage and only exists to sell gabapentin. It proves nothing. It's an embarrassment, really. The goal of highly active antiretroviral therapy is complete suppression of the viral load. Some patients don't get complete suppression. It hangs around between, say, 50 and 1,000. I suppose under those circumstances, you should call it fairly active antiretroviral therapy. The acronym will make me giggle. The question is what to do about these patients, since having persistent low-level virus in the blood leads to increased risk of virologic failure and increased mortality. The other question is, do these patients get more resistant virus because they continue to have replication in the face of medication? And the answer is, drum roll please, yes. In this CID article, they looked at the viruses found in patients with viral load between 50 and 1,000 and found that 37% of the 54 cases had new resistance mutations. So yes, indeedly do, it does happen. Once at Noon Report, the discussant put heart on the board, and I told him, no, it's fairly active antiretroviral therapy. He changed the H to an F, and hilarity ensued. BTW, see, I'm hip to the texting lingo. The New England Journal of Medicine this month has a great review on HIV drug resistance if you want all the gruesome details. So there was this trial to prevent the spread of HIV from mom to baby. And what they did is between weeks 26 and 36 weeks of gestation, the mothers were randomized to lopinavir, ritonavir, zidovudine, and lamivudine, or abacavir, zidovudine, and lamivudine. You had an NRTI group or a protease group. And interestingly, those who were on the protease-based heart had an increased risk of preterm delivery, although it did not affect infant hospitalization or mortality. The risk was 2 times higher, and the women in the protease group also had less weight gain, which may have been a factor in the premature births. Or there may be, as of yet, other yet to be discovered mechanisms. It's getting to be flu season again. Every year over at Medscape, I publish my 10 reasons you're a dumbass not to get the flu vaccine. This is directed towards healthcare workers, because healthcare workers, I think, should know better. The study in MMWR looked at vaccination rates in healthcare workers and compared the difference between vaccinated and unvaccinated. Overall, vaccination rates were about 63%. But the unvaccinated group was more likely to think that the vaccine was not worth the time and expense, would not protect people around them, would not protect them from getting influenza, did not think influenza was a serious risk to their own health, and did not think the vaccine was safe. So, it turns out that I'm right. The reasons you don't get the flu vaccine are because you're a dumbass. All the above are not true, and healthcare providers should know better. Another study, this one out of China, that demonstrated that the early use of glucocorticoids and H1N1 led to increased disease and increased death. It is a bad thing to give steroids with acute H1N1. This is now, I believe, the 3rd clinical trial to show this result. And as always, steroids have to be tried in every illness, with the possible exception of Cushing's disease. I know I've said that joke many times, but not everybody has heard this podcast before. I think it's sufficient to say H1N1 plus steroids equals bad idea. This summer, a couple of kids sickened with a new strain of swine flu. This one is an H3N2. This is interesting and may or may not become an important part of the ongoing flu pandemics. They were interesting also in that they did have one gene segment that is in the H1N1 virus. So influenza continues to reassort and come up with new strains. And swine remain an important source of human influenza, even since H1N1 has become part of the background noise. This particular strain also has the matrix gene. It's probably named that for a reason. The problem with all clinical trials is that they always turn out to have flaws and biases that aren't always noticed before the trial starts. So they have the concept of the meta-analysis. The theory behind a meta-analysis, if you take separate piles of cow poo and you put them in one great big pile, they become gold. This trial, or this meta-analysis, looked at 11 randomized trials and the effect of oseltamivir on the risk for lower respiratory tract complications. And they found that by taking oseltamivir, there was a 28% overall decrease in requiring antibiotics. And if you had confirmed influenza, and often it's a clinical diagnosis, the rates of antibiotic requirements went down by 37%. So it would look like if you have flu and you have influenza therapy, you're a little less likely to go on to develop a bacterial complication, as best it could be told anyway, from piling all the cow piles into one big pile. Almost half of U.S. women have HPV. The overall prevalence is 42.5%. It increases as age increases and with the number of sexual partners. The interesting thing and the good thing is the vast majority are due to non-oncogenic types of human papillomavirus, though HPV 53 and HPV 16 accounted for almost 5% of HPV in American women. It is a common infection, but fortunately, cancer-causing and anal genital wart-causing strains are less common. I do not know how your institution is testing for C. diff. We use PCR at my hospitals. This study looked at 132 patients who had C. diff by PCR, and 32% of those patients had a negative EIA for toxin. Those with the negative EIA did no differently than those who had a positive PCR and had the same risk for transmission of disease in the hospital. So you really can't trust a EIA to rule out your C. difficile. You want a PCR instead of an EIA. So the song should be Old MacDonald had C. diff, E-I-E-I-A. It should be Old MacDonald had C. diff, P-C-P-C-R. I think I need to get out of the sunshine. Some things are just depressing. This week, I was given the senior discount at McDonald's without asking. My beard, which is now mostly gray, is saving me 30 cents on a cup of coffee. Now, the other depressing thing is peanut butter. I have eaten easily 50,000 peanut butter sandwiches in my life. Pretty much all Jif, by the way, which, I don't care what you say, is the superior peanut butter. This study in the New England Journal of Medicine looked at a multi-state outbreak of Salmonella typhimurium, and they traced it back to peanut butter and peanut butter-containing products. I mean, you can't really get more depressing unless they had an outbreak in beer or ice cream, and there have been outbreaks of Salmonella in ice cream. They do not know how the peanut butter got contaminated. They suggest perhaps rainwater leakage into storage areas, perhaps inadequate temperatures in the peanut roaster, and perhaps the Salmonella came in on raw peanuts and survived processing. Be that as it may, I now need to deep fry my peanut butter sandwiches. Because regular listeners know my theory, you die of your specialty. I am destined to die of an infection. It makes me glad I'm not in OB. Bacteria talk to others of the same species. It's called quorum sensing, and they talk back and forth to cause differentiation and growth and elaboration of toxins and other virulence factors. But interestingly, bacteria sometimes talk to each other, or at least slap each other down. This study looked at Lactobacillus reuteri, and Lactobacillus reuteri makes cyclic dipeptides. And what do these cyclic dipeptides do? They suppress toxic shock toxin 1 production by Staph aureus. Interesting. So perhaps having the right vaginal flora could be protective against developing menstrually related toxic shock syndrome. Ooh, I'm feeling psychic. I predict a probiotic concoction that promotes its toxic shock reducing potential. Ooh, I need the James Randi $1 million. But mark my words, someone will soon produce this. This is an article out of Greece. It's on limb salvage and gas gangrene. That was not of particular interest. What I found interesting was the etiology of the gas gangrene. The patient was a heroin user who came in with shoulder gas gangrene. Quote, intramuscular injections with normal saline in the shoulder were also reported. This is a practice among illicit drug users used to provoke pain for recovery after drug-induced coma. End quote. I don't know if that is popular in the United States or not. I have not heard of that as a way to wake you up after going into drug-induced coma. I'll have to ask around my heroin users and see if they do anything like that. Drop me an email if your heroin users do it. Regular listeners to this podcast, and by regular I mean people who listen frequently, not those who have good bowel movements, but regular listeners to this podcast know my affinity for macrolide antibiotics. Not only are they antibacterial, they also have anti-inflammatory and other immunomodulatory properties that make them interesting agents to treat infections with. So this trial looked at exacerbations of COPD in patients on macrolides. Patient either received azithromycin or placebo for a year, and they looked at the number of exacerbations of COPD. Those in the azithromycin group had 1.48 exacerbations per patient year, as opposed to 1.83 in the patient receiving placebo. Hardly an overwhelming response. They did not look to see if there was an emergence of resistance in these patients, and they had more hearing loss in those on azithromycin, 25% versus 20%. Again, not an overwhelming difference, but given that there were almost 1,150 patients in the trial, that did reach statistical significance for the exacerbation and almost for the hard of hearing. The hard of hearing was 0.04. So adding azithromycin probably decreases exacerbations of COPD. Given the difference, it's hard to know whether it's worth the cost and the potential effects upon the microbial environment, as well as on the effects on the patient's hearing. Let's move on to the no good deed goes unpunished section of the podcast. The pneumococcal conjugate vaccine has seen a marked decrease in disease due to the strains covered by the vaccine. Interestingly, one of the many things that's happened since the vaccine has been introduced is that empyema rates due to pneumococcus has gone up. It's gone up in patients aged 18 to 50 from 7.6 to 14.9%, with the incidence going from 0.5 per 100,000 person years to 1.6 per 100,000 person years. The reason is that most of the empyema in the post-vaccination time are due to serotype 1, which accounted for 43% of the empyemas, and serotype 3, neither of which are covered by the vaccine. So what has happened is that the overall serotype of pneumococcal disease has shifted from the predominant strains, which are now covered by the vaccine, to less common strains, which of course are now more common, and serotypes 1 and 3, if you get it, are more likely to cause empyema. As I say, the rule in medicine is no good deed ever goes unpunished. The other interesting thing is that, and we already knew this had happened, that in the pre-vaccine era, there was 72% penicillin resistant. In the post-vaccine era, it's 91% susceptible to penicillin. So the susceptibility rates have gone to penicillin from 72 to 90%, for cephalosporins from 88 to 92%, for macrolides from 76 to 84%, and quinolones have fallen slightly from 100 to 97%. So we have more invasive disease with empyema, but we can treat it with penicillin. Weird what happens when you give the vaccine and it's applied to populations. The other ongoing theme in my podcast is that infections are inflammatory. Inflammatory is prothrombotic, and prothrombotic leads to clot. This study out of Taiwan looked at patients with acute mycoplasma disease, and those who had mycoplasma had an increased risk of stroke compared to those that did not have mycoplasma. The percent in the mycoplasma rate was 1.1%, and the non-mycoplasma rate is 0.72%. I think the thing to do is to invest in stock in the non-Coumadin blood thinners, because I bet you 10-15 years from now, everybody admitted with an acute infection is going to be sent out on some form of anti-thrombotic agent. And the newer non-Coumadin ones appear to have great promise. I'm investing all my money in beer and ice cream. And there's an important rule of thumb. If you take financial advice from a doctor, you are a fool. By the way, I just noticed that my marker system is screwed up. I hope to get it under control now, but up to now, I'm one marker ahead if you're doing M4A. If you're listening to MP3s, you don't care. But if you're following along and want to go back, the markers are screwed up and I'm too lazy to fix it. Continuing with my benefits of anti-inflammatory concept, the issue as to whether or not statins are beneficial in decreasing mortality due to infection is still all based upon retrospective studies. There's no randomized placebo-controlled trial. But this study in the Journal of General Internal Medicine looked at statins started in the hospital on patients who have pneumonia and subsequent outcomes. And they found that if patients were started on statins, there was a modest reduction in mortality pneumonia in patients who were outside of the ICU. So, there have been a bunch of studies that have shown varying responses and outcomes in patients who are on statins, both before they get admitted to the hospital and when they get started on statins while they're in the hospital. The results are all over the map. But that being said, statins do have anti-inflammatory properties, immunomodulatory properties, and it may be of more benefit to patients than decreasing their cholesterol. Because, after all, cholesterol is a testosterone precursor. And rather than take a statin, I would personally prefer to will my cholesterol down the testosterone pathway. You wonder how that's working out for me. Again, our tour of interesting things in the world. IV drug users will filter their heroin or other drugs before injecting it, in part to get rid of particulate matter that can cause problems like talc lung, etc. If you use cotton balls and they're not sterile, well, there's a boll weevil that likes to live in cotton balls. It carries Enterobacter, and cotton balls can be infected or contaminated with Enterobacter and subsequently cause issues in patients who use them as a filter for their heroin. The French evidently are much more forward-thinking. Not only do they provide sterile cotton balls to patients, but they have the IDUSF, which is a free sterile cotton filter that are inside a sterile single-use cooker, the SteriCup, that's given out as part of needle exchanges in France. So in France, you have a government-approved, everything in France is government-approved, filter. You can get sterile cotton balls, or you can get and use your cigarette filters. And those are evidently the three most popular techniques for filtering your heroin. The take-home message actually is that the choice of filter can lead to subsequent infections and may be the source of a weird bug. I had a heroin user recently who was using non-sterile cotton balls, and he indeed had an Enterobacter bacteremia. So this is not unheard of. And it is also part of what makes infectious diseases just continually so cool. All these neat little associations that you don't get to find in the other subspecialties. Candida fungemia frequently affects the eye. How often does it affect the eye? This was part of a study comparing voriconazole versus ampho followed by fluconazole in patients with candidemia who were non-neutropenic. They had a total of 370 patients, and they found 49 had candida in their eye, and another 11 developed abnormalities in their eye during treatment. So at baseline, 49 had candida, and subsequently 11 more. So a total of 16% of patients with candidemia developed some sort of eye finding. The candida was usually chorioretinitis, which accounted for 34. 20 with possible candida eye infections also had chorioretinitis, and 6 had endophthalmitis. Patients with eyeball involvement had a longer duration of fungemia, 4 days, and the treatment apparently was the same, successful in 65% of the outcomes and not evaluable in 32%. So the question is always, can you use the ophthalmologic exam prospectively to diagnose patients with candida in their eye? I think anybody with candidemia probably deserves a good eyeball exam at some point in their treatment to see if they have involvement of their eye. It may make you want to go longer with the therapy. And about once a year, I get the folks from ophthalmology to dilate up eyes, and I've made the diagnosis of presumptive candida chorioretinitis on that basis a couple of times in my career. Although I will say up front that the one study I'm aware of to diagnose patients that way suggested it was not of benefit. There was a study that looked at the fitness of Candida albicans that are mutated with resistance to a kind of candidin, and they found that if you have the FKS1 mutation and are unable to be killed off as well by the echinocandidins, that the Candida becomes less competitive, has less fitness, and decreased virulence, which they conclude, quote, may limit their epidemiologic and clinical impact. To which I will note that initially that may be the case, but generally speaking, resistant strains will over time become increasingly fit in an antibiotic-containing environment, and like MRSA today, will probably be just as fit as wild type. As best I can tell, the effect of mutations upon organism fitness is a transient phenomenon. Though transient may be years, it eventually is overcome. Though believe me, I'm no expert in that area. It's more my gestalt in reading the literature, and I'm sure my gestalt is wrong. As another study shows this month, if you've been on prior caspofungin, when you become fungemic, you're likely to have a caspofungin-resistant organism. So much for limiting clinical implications. Toxoplasma rates in China, according to this study, are about 12%, and it has been increasing in China, up from 7.9% back in the 80s. This is in contrast to France, where 75% of people are seropositive for toxo, and 20% in the United Kingdom are seropositive for toxo. Some areas in China, the rates of toxoplasma serology positivity are 1 in 4. There are also several studies to show that being seropositive for toxoplasma makes you more likely to have a car accident, and it makes you slightly more aggressive. Now, I don't want to say there's any association between the fact that they drive like a crazy bat out of hell in France and everybody there is toxopositive, but it does make you wonder, doesn't it? And unless you think I'm bashing on the French, just let you know I'm a big-time Francophile. But they do drive like lunatics. Of course, I love reporting infections after acupuncture, and there's always one every couple of months. This one was a lady who was getting trigger point injections and as a consequence developed a retrosternal abscess. That unfortunately was culture negative, but her only risk was trigger point injections in the area. What would Roy Rogers say? And finally, I think of people like Pigpen, the Charlie Brown character who's always in a cloud of dirt. In the real case, we're in a cloud of skin and bacteria. Watches, rings, beepers, cell phones, ties, stethoscopes have all been cultured and found to carry pathogenic bacteria. This study looked at doctors' uniforms and nurses' uniforms in Israel and found that 63% of the uniforms, when cultured, had bacteria in at least one site. Of these, 14% of the nurses' gowns had antibiotic-resistant bacteria, and 6% of the physicians' gowns had antibiotic-resistant bacteria. I think there's only one solution to the problem, and that medicine needs to be practiced like the original Greek Olympics. Everybody nude. That way you could alcohol down everything, and think of the weight loss benefit that would accrue. The health benefits would be tremendous. However, you may have an increased amount of people not coming to work due to fear of nausea. You can't win, can you? But the important thing is good hand hygiene, because when you touch your shirt, then you touch the patient, then you spread the bug. So anytime you're about to touch a patient, alcohol your hands. Sadly, my friends, we are at the end of this podcast. This has been the Persiflager's Puscast, a review of the infectious disease literature for the last 2 weeks of August 2011. There is no CME. Big bummer. This has been brought to you by Pusware, LLC, publisher of the Infectious Disease Compendium, a Persiflager's Guide. Free on the interwebs, but available as an iPhone, iPad application, as a Mac application, as a Windows application, and someday when I get the time, an Android application. Now that you've listened, go online, go to iTunes, write me glowing reviews, because my fragile ego demands glowing reviews. Now, my growing multimedia empire can be found over at moremark.squarespace.com. I also do the Gavado Puss podcast, the Quackcast podcast. I write every other week for the Science-Based Medicine blog. I do an infectious disease blog over at Medscape. My essays have been collected as a Kindle book, which is now only $2.99, the lowest price I can charge on Kindle and still get 70% of the proceeds. If I sold it for less, I'd only get 30% of the proceeds. And I'm worth $2.99, don't you think? The world needs more Mark Crislip, and there's a lot to be had over on my website. Otherwise, this is copyright 2011 under the Creative Commons license, And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye.